You got some metal in you? Should I take it out? Should I leave it in? This plate and screws is hurting me, Doc. I need this thing out. When the weather gets cold, boy, does my leg ache. It's got to be those plate and screws. What should we do about this? Stay tuned. Hello folks, I'm Dr. Lyle Ashberg, your friendly pediatric orthopedic surgeon and hip specialist, coming back to you with a new episode of the Orthopedic Health Nexus channel. Today I thought I would discuss something that I get questioned a lot about is, what should I do with this hardware or the surgical implants that are in my body, such as these plates and screws? And although it may make sense to take these things out routinely almost, that's not really how things work or should work, and we'll discuss why that is. You know, in the past, when people broke things, we would oftentimes fix them or stabilize those broken bones with either a cast or a brace or a boot. In the old days, we even had things like wooden splints and wooden teeth and all various kinds of porcelain and ivory devices in order to get your bone stabilized or replace something that was missing, such as your teeth. But today, putting an implant or fixing someone's bone from the inside and sometimes from the outside provides a much improved level of stability, allows earlier return to function, allows the person who's been treated to get pain-free sooner rather than later, and with very little downside in most instances. In fact, at most times it's preferable. So as we've gotten more developed, we're doing more and more implantation of things, even in children. And so in my day, we had the $6 million man, which a lot of people may remember. And although that's not our goal of getting you there, that does happen. I mean, look at Travis Pastrana, the famous motocross racer and trickster, who has multiple fractures and has had multiple implants placed in his body, and they remain there to this day. Now, we also do things like artificial joints, which allow tremendously improved function and quality of life and diminishment of pain in people. And these have been some of the most successful operations of all time. So in today's episode, we'll discuss the types of implants that we use in orthopedics, the materials that are used, how those materials interact with the human body, such as causing cancer or allergies or untoward effects, and if and when, or even if they should come out. So I'm going to limit today's discussion really to orthopedic trauma, because that's the most common time that we'll discuss taking out orthopedic implants, although there are situations with joint replacement or even spine surgery where we might take an implant out for some reason or another. But that is a very complicated discussion which has its own nuances, which we'll stay clear of today. Let's consider some general things, though. So when we talk about orthopedic implants, it's not just happening in the air and floating around in pie in the sky. It's in a human being. And so there's often this discussion about the host and the external factor that affects that host. So we're talking about the person and the implant. And when talking about the implants, there are in orthopedic trauma, there are various kinds that we talk about. There are things like plates, which are fixed to bone with screws. There are pins, which come in the smooth or threaded variety, which tend to be used more commonly in children, although they can be used in adults. There are wires, which are oftentimes used to affix external devices through the skin to a bone, similar to things like, almost like a bicycle spoke, if you will. There are rods or nails, for lack of a better term, and these are things that are fixed on the inside of the bone because the long bones of the body, such as the femur or the thigh bone and the tibia or the leg bone, have a hollow canal on the inside of them wherein you can place a metal rod or any rod, so to speak, and then affix it to the bone and use it as a supportive device from the inside. And then, of course, I've touched on briefly on joint replacements, which actually go ahead and replace both sides of the articulating or the part of the joints that are moving against one another with various materials. But we also need to talk about the host. I mean, where's the stuff going? We can talk about people who are healthy or unhealthy. We have considerations. So if you are fully fit, lean, muscular, functional, that brings into some considerations. Or if you're unhealthy, like you have diabetes, you have obesity, you're a smoker, those types of things would be taken into consideration when deciding what, if anything, to do about the hardware in your body. We need to discuss age because that plays a big part, right? And that kind of comes back to the healthy thing, but really one of the major distinctions there is, are you dealing with a child or are you dealing with an adult? Because children are growing, and that changes things and has an effect on our decision making. And a lot of people feel that as children become adults, we don't really want to leave anything from their childhood that might affect their adult life or potential procedures in their future as an adult. We also, when I mentioned healthy versus unhealthy, there are certain bone diseases that are quite common. So osteoporosis is considered a bone disease, really, because it tends to be a disease of aging, where as you get older, the quality and the integrity and structure of your bone tends to diminish over time as you lose calcium. And that would be a consideration when thinking about implants or hardware. And then there are some childhood diseases that have similarly an equivalent effect, such as osteogenesis imperfecta, which is where children don't really form their bones normally. And one would be very cautious in managing those kids, and even on occasions in disease processes like that, we might consider leaving the implants in and using it as a supportive structural device as children go through their entire growth. Now, when I touched on the type of implants, in trauma, there are different materials that are used in these implants, and for the most part, the two main kinds that are used are stainless steel and titanium, where stainless steel is primarily a combination of nickel and chromium. Titanium comes in various grades, but suffice it to say, both of these are so-called surgical grade, high-quality metals, and each of them have different characteristics that might be more body-friendly, if you will, and have a much better propensity to be tolerated over a long term. Their structural characteristics are also important when deciding on how or which type of metal one might use, and different orthopedic surgeons have different opinions about that, but we often talk about things like modulus of elasticity, which means that the structure of these materials have a certain bending and stress characteristics that may or may not be closer to that of the modulus of elasticity of a bone, or the structural characteristics of a bone. So those are some of the things that we take into consideration when we put these implants in. But now let's talk about the topic of when to take these out, right? Should we always take these out? What are the circumstances that we might consider leaving them in versus taking them out? I mentioned one, that in sometimes in childhood, bone diseases such as osteogenesis imperfecta, we might leave that implant in for a long time to allow that child to grow in a supported way over the implant until they reach skeletal maturity or until their bone quality has improved. But when we're operating on people in any surgical field, and orthopedics included, we talk about indications. In other words, why should we do it? What are the circumstances? So there are really just three absolute indications for taking out hardware. The first one is an exposed implant. In other words, one that's sticking out that you don't really want to be sticking out of the skin, because obviously that's unsightly, number one. Number two, it really increases your chances of getting an infection, and that is by definition a wound problem, which by extension may result in a wound infection or worsening problem, or even deep infection, which is disastrous. The second reason we might take out an implant, or absolute indication for taking out implants, is infection, which I alluded to about with the exposed hardware. But infection is one of the absolute indications for removing hardware. And the reason for that is because when you have infected hardware or implants, your body's immune system is unable to get to the bacteria to assist in the killing of the bacteria. And on top of that, antibiotics are unable to get there as well. And the reason for that is because bacteria form these little films around them called glycocalyx, which is literally a physical barrier that prevents the influx of blood supply, of medications such as antibiotics, and to your immune system. And so one of the definitive ways of treating an infection in a bone, for instance, that is associated with an implant is to actually take out the implant, if at all possible, and then begin the antibiotic process after you've done surgical cleaning of the area, or debridement or debridement, whichever way you like to pronounce it. So exposed implants, infection, and then the third absolute indication are implants that have migrated into dangerous places. So sometimes you'll have a screw that's too long that might be tickling a vital structure, such as a nerve or an artery. And sometimes in things like you see in kids, where the bone has grown and the screw has moved with the growth of the bone, those screws might suddenly become, where they were fine initially, over time they might become too long or have moved, where they potentially cause damage to an overlying structure. So in those instances, that would be an absolute indication for removal of those implants, given the correct circumstances, of course. There are a lot of relative indications for taking out implants. So one would be an implant that you know is definitely the cause of the symptoms. In other words, some implants are just below the skin, like in the collarbone or on the outside of your ankle. You can feel those just below the skin, and every time you put your shoe and sock on, or you put a backpack on, if you've got a clavicle injury, you might feel that implant there, and that would be a relative indication to remove that. If the implant looks like it's about to poke through the skin, or the skin is tented or very tenuous over the implant, then you might consider taking out that implant. If you have a broken implant, there's an argument to maybe take those out, particularly, again, if they're causing one of the aforementioned problems. Some families just don't want hardware or metal in themselves, or their kid, or their granny. And so sometimes families want it out. And then lastly, and in one study, in the majority of cases, it was the surgeon that said, we should take out that implant. And you'll find that a lot in the pediatric realm as well, where pediatric orthopedic surgeons tend to suggest that hardware be taken out prior to the child finishing their growth, but after, in the situation of a fracture, the fracture has healed. And then lastly, there are some instances where we put implants in where we actually plan to take it out, such as if we put an external fixator on a person. An external fixator is a device that connects to the bone from the outside via a ring or a bar, and goes where a pin or a screw goes through the skin and attaches to the bone in order to stabilize the bone from the outside. And we would plan to take those out. And sometimes we do things like in pediatric orthopedics called guided growth, where we actually put the screws and a plate to span a growth plate, to go across the area in the bone where it's growing, in order to direct the bone or guide the bone to grow in a certain way by using the power of the growth plate while tethering one side or another. So those are sort of the absolute and relative indications. Now, when we discuss implants and their relationship to people's bones, we often talk about bones that are weight-bearing, such as those in the lower extremity, in the leg, and those that are non-weight-bearing or mostly non-weight-bearing, such as in the upper extremity, such as in the arm or the forearm, and the effect that gravity has or weight-bearing has on the structural integrity of those bones. And the relationship with implants is that there are some implants, particularly when we think about the lower extremity, where we have implants that are load-bearing. In other words, they take the load away from the bone. And those tend to be things like plates and screws, as opposed to load-sharing implants, which are things like intramedullary rods or nails. So when I say intramedullary, I'm meaning within the canal of the bone, and those tend to be load-sharing. So in the load-bearing situation, the bone underneath the plate and screws, or the load-bearing implant, tends to undergo what's called stress shielding, where because there's not as much stress and strain on that bone underneath that plate and screws, the bone may actually become thinner and less robust, as compared to load-sharing implants, where the implant shares the load over a period of time, and then as the bone completes its healing, the bone takes over and then the implant becomes superfluous. Now, in the upper extremity, that's not as much of a big deal, but the bone that's just next to the implant as well may be at risk of fracture, and this is sometimes listed as a reason to potentially take out a plate and screws. And were you to injure yourself again, you could potentially break the bone right next to where the plate ended or the plate and screws ended. So that is a consideration as well. So these are all theoretical concerns that orthopedists and scientists have brought up as to the potential reasons to either leave implants in or take them out. I think one of the biggest things that guide us as to whether or not to take out an implant or leave it in has to do with the risk versus the reward. In other words, how easy or how difficult is it for us to take out that implant? Will we be causing a lot more structural damage by taking it out? In other words, we're doing more harm than good by taking it out than leaving it in. What are the tools that are necessary to take it out? Is it going to be something that's extensive? Is it going to be, again, that comes down to the easy or hard thing. And I speak from experience that there's a saying in orthopedics that nobody looks good taking out hardware, which means that oftentimes taking things out that sometimes even look easy are really a struggle to get out of a person's bone. And I can tell you that there's a handful of times that I got defeated and gave up. Now, when we're talking about risks, we need to understand that any time that you make an incision on somebody, no matter how careful or how good you are, there can be complications. And in one study, there was a 10% risk of complications after elective implant removal, which is really high if you consider that infection for primary surgery under clean circumstances is generally less than 1%, or even a lot less than 1%. Depending on the surgery, they can be higher or lower, but in most orthopedic surgeries, it's less than 1%. So a 10% complication rate to electively take out an implant is pretty high. So you need to be pretty clear in your indication, I think. And the type of complications that they saw were, the number one was wound problems, so poor wound healing, which followed very closely on its heels by infection, which comes along oftentimes with wound infection. And that doesn't always limit itself to the skin. It can actually end up in the bone. And again, as I mentioned earlier, once you get a bone infection, that is a really unhappy situation and difficult to cure. They had some nerve injuries, and another common one is incomplete implant removal, which you may or may not call a complication and may be expected in some instances, but again, it can be listed as a potential complication. So when I talk about the difficulty or ease of taking out an implant, we can talk about where it is located in the body, but we can also talk about the type of implants. So, plates and screws that are pretty close to the skin right there are usually fairly easy to take out. barring the screws being stripped or cross-threaded, or sometimes you get what's called cold welding, where the screw actually welds itself to the plate underneath it. And just like in any hardware situation in woodworking, you can have stripped implants that make taking those things out pretty challenging. But remember, you're dealing with a living, breathing, functioning human being. And then, of course, location, right? Just like real estate, the more deeply buried it is, the more difficult it is to take out, the higher the risk is to the patient. And there are certain instances, like in the spine, where taking out implants electively may be pretty risky to do, and in most instances is avoided. Another thing that often should be taken into consideration is what I call the 3 C's. So those are the costs associated with taking out that implant, and those can be substantial, both in realized costs, in other words, the operative time, the tools that are necessary to remove the implants, and sometimes people end up staying in the hospital for a day or two because of pain or blood loss or whatever that was associated with that surgery. The second C is compliance. So in kids, which I deal with quite a bit, if I've taken out a plate and screws in a kid and there's little holes in the bone, those little holes can be a risk for fracture, and generally we put those kids on a set of crutches for a period of time after the implant is taken out. I can see this applying to an adult as well. And if a child is not compliant, they could refracture through one of the holes. And then, of course, the last C of the 3 C's that I made mention of are cohabitors, or the people that live with you. What's the cost to them, right? Do they have to take off work for you to have your implants taken out? Do they have to help you at home? Do they have to do everything for you because you are now infirmed? So there are other relative things that I talked about as well, such as the risk of fracture. So one has to take those into consideration, but those, again, are things that can be mitigated by other measures, such as using crutches, etc., but those still exist as a potential risk versus reward. If we revert back to the host component of this, we do need to discuss whether this is a child or an adult. And although the indications for leaving implants in or taking them out are very similar in both groups, children have this unique thing in that they grow, which means that their bones are changing over time, both in length and width. And because they're growing, the rate of formation of their bones is rapid. And indeed, it is not uncommon, if you leave an implant in a kid, for it either to migrate or move as the bone grows away from where the implant is, or for the bone to grow over the top of it such that it becomes ensconced in the bone. It basically becomes intraosseous, or within the bone in some of the most extreme circumstances. And the considerations of when the child becomes an adult, such as if they need additional surgery or a joint replacement or something in the future, of how it affects that function or the ability of the next surgeon to address potential orthopedic issues in the future, comes into consideration, considering a lifespan with an average human living until they're about 75 to 80. So of that time, that obviously increases your chances of having to have another orthopedic procedure in the future. And so the tendency is that pediatric orthopedists tend more often than not to recommend removing implants while considering all the potential risks involved. You might ask, is there a risk of leaving these implants in? In other words, is there a risk of cancer? Are these things going to rust or corrode? What if I'm allergic to the metal? Because that does happen. And what if I do need future surgery, which I touched on briefly here a few minutes ago? So let's touch on some of those situations. Generally speaking, leaving implants in patients is a benign thing. And with all of the literature that's out there, and now again, I'm mostly focusing on trauma, because if we talk about joint replacement, we can talk about metal on metal corrosion, metal on polyethylene or plastic that have been shown to be problematic in some instances. We'll just focus on the trauma side. Leaving implants in has generally, to the best of our knowledge and with all of that data that's out there, found to be safe. And when looking at corrosion, in other words, do these things rust, one of the ways we can look at that is, other than looking at it by opening up the skin and looking at it, is to look at metal ions that are floating around the bloodstream. And generally speaking, with the surgical grade stainless steel that we use and titanium that we use, those ion levels are almost undetectable even over long periods of time. So corrosion doesn't tend to be a thing in most instances. Now, it can occur if you use, or is more likely to occur, if you use dissimilar metals, just like you may have if you did that in carpentry. And we try to avoid that because, yes, there are salt ions floating around the blood, which and particularly if you have dissimilar metals, you can have electromagnetic charge develop or a battery type effect that can result in corrosion. So we avoid that in orthopedics by using similar metals, or if we use dissimilar metals, we don't let them touch each other, which is what causes the battery effect. And although we never say never in medicine, and we never say always either, there are a few case reports of cancers which people feel are associated with corrosion, but that is exceedingly rare. The next thing that comes up quite often is the correlation between cold weather and pain related to an implant. And in all of my literature search, I was only really able to find one study that talked to this, and particularly that was addressing implants, and it came out of Saudi Arabia, of all places. Now, I haven't been to Saudi Arabia, but I believe that it's pretty hot there. So, that kind of made me think, all right, what's going on here? So they looked at patients who were getting exposed to air conditioning and asked them whether they were experiencing pain related to the implants, which, by the way, introduces some bias, right? Are you having pain from your implant? In patients who had had surgery. And less than 50% of the people, 49% to be exact, complained of pain, which they felt were related to their implants. And 30% of those patients had pain within a year to 3 years after their surgery, and another 30% had pain more than 36 months after their surgery. So, again, is there an association? Maybe. Is there a correlation? Maybe. But I'm not sure. So my questions about this study was the implant really the cause, or was there some other reason that they had pain? Is air conditioning or the cold from air conditioning enough in Saudi Arabia to cause pain secondary to cold? Possibly. And what was also notable is there was no relationship between age, the type of implant, where the implant was, the timing, or even the occupation. So I'm not sure about it, but again, there are studies that show that people who have arthritis or have had a fracture will have pain with cold weather, and that seems to be a common thing, and it may have to do with blood flow, but is it related to the implants? I'm not sure that that's clear. Now, speaking of implant pain, we can talk about real and imagined pain. Just having something in your body that's stationary and is not moving does not necessarily mean that that's the source of your pain. With that said, there was one study where 96% of patients who had elective implant removal for pain reported that they had decreased pain, and 72% of them said they had improved function. Now, again, this is not necessarily cause and effect, because if you're saying that you have an implant that is causing you a change in function or loss of function, one might presume that those implants are either in a joint or pushing up against something structural that they shouldn't be, or inhibiting the motion of a joint. In other words, why was it that it was causing a loss of function? And if you have a loss of function, one might also make a presumption, not an assumption, a presumption that this might be causing pain as well. So does A equal B? I'm not entirely sure, because there are lots of other studies where implants have been removed and the patients did not get any improvement in their symptoms, even 50 to 60% of the time. And there are some surgeries that show that when patients left the implants in, they actually felt better with them in than with them out. So how do you interpret those things? What's interesting about the first study that I mentioned is they had a 10% complication rate, which is one of the data that I reported earlier. But of those 10% people that had a complication, 66% of them said they would do it again. So I think that says something, right? If you're feeling like the implant is the cause of your pain problem, but you have a complication which is presumably worse than having your implant electively removed, but you say you would do it again, perhaps just the thought of having an implant might be the reason for your pain. I wonder. Nevertheless, we will not discount that some people feel better with their implants out, and so we'll give them a pass on that and say, if it's not risky and it's not going to cause you too much harm, let's take it out. Another thing I want to talk about is implant allergy. This seems to be getting a little bit more common, particularly as people wear metal jewelry, such as earrings, nose rings, piercings, even bracelets that have metal in them. And oftentimes the metal that causes the problem is nickel. And in one study, approximately 17% of women and 3% of men are allergic to nickel, and 1 to 3% are allergic to chromium, which I noted is what makes up stainless steel. And how we find that out sometimes is by allergy testing. And there is general allergy testing, and there is metal-specific testing that you can do. And the American Contact Dermatitis Society recommends skin patch testing before device implantation in patients who have clear metal allergies, clear documented metal allergies. With all of that said, again, the literature on this is not definitive, in that there are a large number of patients who are found to have allergies to metal and have negative allergy tests, but have positive allergy tests when doing blood tests for the allergy, and vice versa. And it also seems that in a lot of instances, even though they may have positive skin tests, they don't have adverse deep reactions or changes in the bone. Still, it is clear that metal allergy is really a thing, especially when we're talking about nickel. It can cause changes in the bone, or how the body reacts to the nickel, just like any other foreign substance, or the metal, just like any other foreign substance. And this can sometimes be mistaken for infection. It can be mistaken for non-union when the bone is not healing, when ultimately it was the metal that was causing the problem. And so certainly there are also foreign body reactions to the metal, which is an allergy situation. So that is a real thing, and we do need to take this into consideration as orthopedic surgeons or even as general practitioners. The last thing I want to briefly touch on is metal detectors. And my patients often ask me, hey, doc, when I go through the metal detector at the airport, will I set the alarm off? And the answer is perhaps, sometimes, maybe. It depends. It really depends to a large extent on the volume of metal that you have in, where the metal is. In other words, is it superficial, like just under the skin in a knee replacement, or is it deep, like in an intramedullary rod, where the rod is in the inside of the bone, or a total hip replacement where it's sticking out of the bone to some extent, but under the skin, but is deep. So there have been a couple of studies that have looked at this, and in one study it was a self-reported thing where less than 50% of the patients said that when they went through, who had various orthopedic surgeries, said that when they went through the metal detector, they set the metal detector off. And in a large percentage of those patients, even when they used the wand on them to try and see if they could detect the metal, it didn't show up. It did show that the more likely instance of the metal setting the detector off was in knee replacements, followed by hip replacements, followed by rods inside the bone. With that said, you can get a card that says, I've had a joint replacement, and you can then show whoever the security person is your scar if you feel you're able to do that. But most of the time, they'll take your word for it and let you go on. So, to summarize, I'd like to give you 3 practical takeaways. Number 1, it's generally safe to leave metal in, and it doesn't absolutely have to be taken out just because it's there, and particularly if it's not causing a problem. There are 3 indications, or 3 absolute indications for taking it out: exposed hardware, infection, or an implant that is causing damage to some structure that it's going through or is nearby. Those would be the 3 absolute indications. And if you can think of others, I'm happy to learn, but those are the 3 absolute indications. And then there are the relative indications, and those might be things like implants that are perceived to be painful. They are just below the skin, where they could be causing irritation every time you take out put your socks on or put your backpack on. They're relatively easy to take out and won't cause more damage. You could make the argument that maybe that those implants that are load-bearing and stress shielding, there might be an indication to take it out. And then we've mentioned that in children, we tend to lean towards taking these out more often than not because of their lifespan and the potential for future problems or issues with growth. And in those ones, we might be more likely to consider taking them out, taking the risks into consideration. But again, not everybody agrees on that, and sometimes this is just family preference. I'll lastly touch on the timing. When should one take these things out, particularly in kids? In kids, we tend to wait till the fracture is healed, and we tend to take them out anywhere between 4 weeks. If it was something relatively superficial, i.e. we plan to take out some pins or things like that. 2 months, if we're doing things like guided growth, we might opt to electively take those out once we've achieved our end goal. To a year, if we're talking about things like a femur fracture, where we might consider taking out the rod from the inside of the bone. Unfortunately, there are no current clinical practice guidelines put out by any of our societies, and so it tends to be a choice and a discussion made between you and your physician. And I guess that's the real takeaway here is excluding the absolute indications for implant removal. Taking out implants really involves a discussion between you and your doctor, the risks and benefits, and the likelihood that you're going to cause more damage than good by leaving them in as opposed to taking them out. Ultimately, even with stuff in you, you can be the $6 million person like Travis Pastrana. Next time, we talk about creaking knees. Why is it that when I go up and down the stairs, my knees hurt and it sounds like they need oil? What's that about? We'll get into it. So, until next time, I hope you live your best life. Stay healthy. Cheers.